case session here, so I'd like to invite panels, Dr. Chan, Zhang, Dr. Fuji, Farlaban, and Dr. Guan, Dr. Go, Margolis, Dr. Murasato, Dr. Nagajawa, Dr. Tan, please.
Can I make a preliminary remark? I just want to make a preliminary remark about the last discussion. The truth is that everybody is not the best surgeon in the world, and every cardiologist is not the best interventional cardiologist, and anybody who's writing a paper thinks he's better than everybody else. But we have to work by the standard of what the average person does in real life, and we cannot gauge our care on the best in the business, which is, of course, is Dr. Park.
Thank you. Okay, we're going to start last live case sessions. Okay. Maurice?
Hi, SJ.
Okay, welcome back.
Thank you very much, and as usual, thanks for the invitation and very kind hospitality. It is impressive of what you and the team at CVRF has done. It's been incredible experience for the last 20 years. So with that, I'd like to maybe let my colleagues here at Asan introduce the case, and then we can start discussing.
Yeah. Hello, ladies and gentlemen. I'm Do Young-gang from Asan Medical Center. This patient is a 61-year-old male patient visited due to chest pain. And the coronary angiogram revealed significant stenosis of left main to proximal LAD and ramus and proximal RCA. We already treated RCA with stent, and we planned staged PCI to left main bifurcation. Can you?
Yes.
Yeah.
Okay. So with that, maybe we can go to the angiogram, and the angiogram shows, first, I think we don't have it, but about 2 weeks ago, the right coronary artery lesion was fixed with a 3 millimeter Zion stent, and it looks excellent. And now the patient is staged for this left main. And I think you could see now on your screen, so this is the right coronary before, next, and not right coronary after that.
Yes, that was the last image.
Yeah, that was the last image
yeah.
at the end, and showing that the good result of the right coronary artery. So, perfect. So now we have a taller task today, which is the left main. It's a 90% diffuse from ostium all the way to the origin of the LAD. Fortunately, it doesn't seem to be involving angiographically the LAD, but we don't know yet because we are going to do what's imperative and what Dr. Park and others have taught us for many years, that IVUS-guided left main implantation is critical. IVUS-guided pre, IVUS-guided post for optimization of the results. And that is what leads to the PCI success and durability for long term. So I think maybe we can show, are you able to see the left injection now?
Yes.
Yes,
so this is the caudal view, the spider view, showing that the left main very tight with an intermediate ramus. On small screen, although you think that it is a bifurcation, it is actually not. It is a high OM as opposed to a true bifurcating, trifurcating ramus. Nevertheless, wiring it was a little bit of a challenge, and we'll talk about it second. It is not a true bifurcation.
Maurice, can you tell us the proximal circumflex in this view looks sort of less dense. Do you think that there is plaque that goes into that, or is that angulation, or tell us about that?
I really think it's angulation, because when you look at the diagnostic from a week ago, it was clear that the ostium of the circumflex was looked fine, and it was not hypodense like it is here. But keep this thought because of what is developing in a second as we talk about the strategy for this case. So clearly, if you are going to do IVUS to identify whether you need to do pre-dilatation, whether you do debulking, whether you have to do a crossover from left main into LAD and make it simple and best results by optimizing that stent is a matter of discussion. Maybe we could do the RAO view now, the next view.
Right.
And here you could see the origin of the circumflex is a little bit unusual. It is more coming out of plane, and you could see that ramus coming few millimeters from the bifurcation.
RAO view suggests kind of just the distal limb main disease.
Yes.
Preparing one Medina 100. However, we have no ideas, and so personally, I prefer IVUS examination before that. And so
we guessed that you're going to do that, and because you are the boss, we are going to do that. But before we do that, we have to wire the lesions. And I chose, and now we can go live a little bit, and I chose to do the maximum safety, which is wire everything. And we wired with difficulty, we wired the ramus, and we wired the circumflex, and we wired the LAD in order to be able to argue with every and any member of the panel about whether this vessel or that vessel needs to be protected. So in truth, I think that we needed really the LAD. We had to, because the angulation is significant, I wanted to be sure that we had access to the circumflex. And finally, if there is somebody who wants us to think about treating the ramus, we have at least that wire for protection. You could see right here the anatomy better. You could see the circumflex that Dr. Holmes was worried about. It didn't look too bad. And you could look at the ramus also. It looked intermediate, not too bad, but a large vessel for a 61-year-old male. So to get back to left main PCI versus surgery, notwithstanding everything that was mentioned in the excellent lectures this morning by Dr. Stone and this afternoon, as we just heard, I think that this patient has a syntax less than 32, has a discrete left main lesion along with the other vessels, and I think PCI is most appropriate approach for this patient.
So did you do the IVUS?
Let's look at the IVUS.
All right. Okay.
So this is from the proximal LAD back.
Vessel size is 3.5.
3.5. Yeah,
Right.
3.4, 3.5.
Mild plaque.
Mild plaquing, a little calcium speck, but mostly soft plaque. And then the LAD ostium right here is, again, slightly restricted. And now we start to see
Circumflex
significant...
takeoff from 6 o'clock. Right.
Exactly, looked okay. And now we're going to see the dense fibrotic, not calcified.
Distal limb main is, mainly the disease confined to the distal limb main area, right? Characteristics itself is a relatively soft one. Okay.
And this is guide.
So would you give us another IVUS long from the circumflex?
We did not do a IVUS to circumflex. Oh, you want the run here? Yeah. You could see it, I think you could see it clearly that at least at the origin, it did not look that where disease was involved at.
We cannot clearly, see that the circumflex OCL part by LED long, right? So
right there.
Usually we need another separate circumflex IVUS
IVUS run. Yeah. I thought that it was clear, so at least for the benefit of discussion, most of the stuff was really related to the left main and the origin of the LAD. And my plan was to do crossover with the wire protection as we have it.
Okay.
The big question now, do you predilate or not? And I chose not to predilate because everything, it's a soft plaque. I don't see dense calcification. And therefore we chose a 3.5 by 24 synergy stent. The lesion length.
Okay. Any suggestions from the
So,
panel?
so,
Okay,
so
Maurice.
Maurice, this is Hui Chim here. So I'm surprised you won't pre-dilate. I think that's one reason why we will pre-dilate in this case, because he at least relieves some of the ischemia, so that even if you take time to position the stent, you wouldn't have too much of a problem dealing with possible ischemia in the left main compared to, yeah.
But the negative also is that you are going to have to be manipulating more, and given the fact that it is soft plaque, I think that what we have done is do it primary because it has maybe less plaque shifting and you deal with everything in one shot. But clearly what you're saying is appropriate as well.
Maurice, it's also possible that with pre-dilatation, you can see if there is going to be plaque shift. That gives you then a sense of what's going to happen with a stent, and that might change your strategy. What about that?
Yeah, but I think that, at the end of the day, I'm probably going to do a crossover and then deal with the circumflex thereafter if there is. So I'm not sure that it's going to help me knowing they will or they will not. I'm going to deal with it as it comes.
Maurice, this is Charles. The ramus is a very big vessel, and I think you really assume that you're not going to do anything to the ramus.
Correct.
I mean, what after stenting the left main, then you got a bit of plaque shift and the ramus origin get pinched. What will you do?
The only way to do it is to stent now the ramus first, have a little bit of stent protrusion into the trifurcation, so to speak, origin, circ, and left main, and I think it will complicate the procedure, not knowing that it needed to be done.
Okay.
Maurice, how about a gel balloon technique where you can just pack a small balloon in the ramus and then you do your stent of the left main, and that can preserve the patency of the ramus?
Yeah, I mean, it's an idea where we could pre-dilate a little bit the ramus. I'm trying to keep it simple and then hopefully not have to deal with any consequences.
Anyway, too many wires. All right.
So I'd like to suggest
My preference is, I want to do the IVUS run from the circumflex clearly, and depending on a circumflex disease, ostial disease, or whether or not I need just a single wires, from the LED to the main,
I
and
totally agree with you.
Right, stent crossover. Ramus branch actually not pretty much plaque on ostial part, and so I don't too much concern about that. And if you look at the spider view, circumflex the angle is quite steep. And so
It was acute
not too,
and difficult.
okay, not too much concern about the compromise the circumflex ostium.
It was very difficult to do. That's why I'm not too much concerned. Exactly.
So what are you?
Actually,
What I wanna do?
can I have a comment? So actually, EVIS guideline recommends a wire in all the significant side branches, actually, but in our COBIST registry analysis published in JACS several years ago showed that the gelled wire didn't protect the side branch as you expected.
It doesn't protect it, but it keeps it marked in case there is slow flow, so you can aim at it if it is occluded. I don't think it protects it, but it gives you a marker in case there's a problem.
Maurice, did
So
the patients tolerate the
Alright.
IVUS interrogation well?
Yep.
There was no
were
ischemia,
issues.
yeah.
No issues. So I would like to go to the RAO caudal.
Yes, I'll call that now.
A little bit test, please.
Test.
Less RAO, more caudal.
Yep.
Yep. Test, big test.
Test.
Good. So this is the stent, and we chose 3.5 by 24.
I like to stent.
Okay.
Well, you certainly have enough length.
We have enough length. We could change it. We could change it because the IVUS measured it at 21.
Okay.
So
It's
I
just a
think
6
that
French guiding catheter?
it's a 7 French guiding
7
catheter.
French.
So now that we have it, we're going to have to, let's go ahead on the spider.
Do you have any tips and tricks on covering the ostium of the left main?
Yeah, so I think what we do is basically cover up to the ostium rather than stop someone in the mid. In this case, there's no issue. Inject, please. Okay, so we write on.
I think it's perfect.
Okay, perfect. I'm going to go ahead, inflate to 10 and 12.
12,
Stay right there.
Okay.
Okay, down.
down,
He's having some chest pain now. Okay, let's take his cine now. Inject.
Good.
Okay, looking good so far. Let's replay. So the circumflex is untouched. The ramus is untouched. So I'm going to take the ramus wire out.
Pull
Does he
the.
have pain?
I don't like black wires in.
Yeah,
I cannot.
I'm
see
going to
that.
take one. I'm going to take one black wire out, and in a second I'm going to take the other black wire out. Inject now.
yes,
Perfect. Okay, so I'm going to come back with the circumflex wire, and now we're going to increase. Go ahead to 14,
14,
and
Great.
down.
down,
Don't worry.
Okay. So we're going to come back now to let him breathe, and stay right there. Okay, let's do a good cine now, please.
yes,
Pressure is good. Inject. Okay.
I like it.
So maybe we can stop it. All is good. And we're going to go post-dilate. And then we'll come. Do they want to go over there a bit, or we can finish here?
as you want.
Would you
Depend-
like to go?
Depending on the IBIS.
Are they ready? Yeah, because what I think what we should do is we should post-dilate, IVUS, and then come back to you if they're ready in the other room.
Okay, is it okay?
Yep.
Yes.
Okay, so we'll go to the other room. We will do this and come back to you.
You will-
Any comments?
Definitely.
Okay.
Yeah.
Dr. Wu, can you hear us?
Yep.
All
Yeah, we
right.
can hear you. Okay, SJ. Afternoon.
Let's explain that. Thank you for joining us. Right?
Okay, so I just introduced my crew. Here is Dr. Lee and Dr. Do. Yeah, this is a real name in South Korea. But anyway, we just want to present the case because a very interesting case. Okay, by Dr. Lee.
Yeah. This patient, 71-year-old female, and she admitted for aggravated typical chest angina 1 year ago. In OPD, thallium spec was done. Thallium spec finding shows normal gait myocardial perfusion. But she complained typical angina. Coronary angiography was performed. Its coronary finding revealed very tight stenosis in left main ostial region, and right coronary angiography shows in ISR at RCA ostial region. 7 years ago, she underwent proximal RCA cipher stents. Next. Echocardiogram is known. Treadmill test, she was in an adequate. And thallium spec, normal gait myocardial perfusion. Syntax scores 13. Next. Yeah. And then we will show you first angiography for this patient.
Okay.
Would you show us the right coronary artery too?
Yeah.
RCA.
Okay.
RCA may be that only the previous angio,
Yeah.
but they have some borderline instant restenosis in the ostium RCA. Okay, can you see that
Yes.
RCA?
Yeah.
Okay.
You can see
So
that.
I can see some narrowing, but however, there was no damping, and backward flow to the aorta is okay. But in this patient, thallium, I don't know, thallium it shows like false negative because large territory and also both RCA, left main osteo have a critical stenosis. So this is why we can explain thallium is negative.
Balanced
But-
ischemia as well.
But because we pick up the more critical stenosis in the left main, so we show it from the beginning because this is very tip and tricks because left main osteo lesion. So before we do that, we pick up a 7th French side hole, XB 3.5. Before engagement, I just put side by side 3.5 wire with 0.14 wire. So light engagement near the osteo, then I quickly switch the wire into either circumflex and already this is our plan. So usually when the LAD osteo have a lesion, left main osteo have a lesion, I do this way.
Do you have a sense, is the pathology different because of the fact that it's a very calcified aortic valve, aortic wall, as well as the right coronary artery is probably also a calcified wall, and it's part. Is this a different disease, or is it the same disease? But
I'm talking with my my assistant. I don't know. It's because I see this quite often in Korea. I don't know. It's a syphilis or otitis or some other aortic inflammatory disease. So the patient actually have a both. She don't have any significant coronary artery significant risk factor. However, they have both osteostenosis.
Next.
So David, you any suggestion? What the etiology?
So, Chong-Rui, is there any downstream LAD disease as well, or we just?
Yeah, they have some in the mid-LAD, but we can show you. So this is our first angio. We can see a very critical in the whole trunk of left main. And we back to, this is iliocranial. And iliocranial, we, after we stabilize the guiding, we can put another wire into the LAD. We can see the mid-LAD also, they have a lesion. So, but because the side hole, the angio is not showing very clear. So we'd like to show you the IBUS.
Okay.
Unfortunately, next one, the IBUS we cannot pass,
Oh, really?
even without dilatation, pre-dilatation. You can see that we have tape recorded it. IBUS casters
Must
of the
be
cross cannot cross.
some calcified plaque.
Yeah. So we have to pre-dilate even with 2 IBUS. So this is a 3-0 by 15. One balloon with a skip away. So I intentionally bring it back into the osteo, holding my caster steady in here. Then we can achieve a little bit space, 16 atmosphere. Then after that, we can do IBUS for you.
Yeah, IBUS, please.
So can you show the IBUS? in the
Yes,
RIT?
you can see that.
This is
Mid portion
mid-
LAD.
Yeah, mid portion.
Yeah, mid portion.
3O vessels, minimal plaque superficial calcification. The diagonal branches is coming 2 o'clock. 3, 5, 4, relatively big one, right? However, the disease is quite diffuse from
Diffuse.
distal.
So that would be 4, do you think, from adventitia to adventitia, or how do you measure that for the audience?
Middle to medial.
Okay.
So this is a mid-area deletion. Also eccentric, the minimal lumina area, 2.7.
Quite enough.
Okay. So we can escape this lesion.
So you, okay.
Or we decide maybe after we fix the left main osteo, we can do FFR for you.
Fix the main first, and then we want to see that what happens.
So I just quickly bring the caster back into the near the osteo proximal portion of the RAT for shortening of our IBUS imaging time. So this is actually from the near proximal portion of the RAT. And circumference just joining from 12 to 1 o'clock
Circumflex
direction.
coming on 12 o'clock, wire
And
in,
this is a distal left main.
all right, big
Not much
vessel,
disease.
almost a 6,
6
7.
millimeters.
Oh, very focal. You know, some
Just-
calcific lesions, post-op
Yeah.
shadows, we cannot,
Yeah.
or very
See,
calcified.
Almost like
Ostial
a
part.
270-degree
All
calcium.
right. We have to cover the ostial part very cautiously, right?
But right now it's a problem because I don't have any DS to fit the osteo.
Yes?
So maybe you guys can tell me.
Why not?
For prepare the lesion better, so after this we do IBUS also from the circumflex. But circumflex is okay, but so because it's very calcified, so we use a 5/0 by 10 intentionally to cracking that lesion. So this is a very hard lesion, 5 by 10. This is a 20. We cannot popping of that very tight osteo. So after 24, next one. This is a 24. We can achieve optimal
5/0?
dilatation. 5/0. Yeah.
high pressure.
And after this, we another IBUS. We can show you how that the IBUS imaging after we do 5/0 dilatation.
If you did 5/0, pre-dilations, we cannot choose, bigger stand. For just 4/0 stand is
4,
biggest
yeah.
one, and If we do 4 or something, it's a 3-5 high pressure inflation, breaking down, plaque, and then 4 stent placement and high, pressure inflation up to 4.8 or 5 something. Okay.
But
I think
yeah,
this is
is
very
after 5.
important to not get too aggressive here, because the whole thing can perforate or rupture, including the aorta where it joins the.
Right.
Do you have an onyx stand here, the large ones?
We have an
Large
onyx.
So,
We check the shaft because that how much we can extend.
anyway,
Turn out
the
synergy. I don't know. Synergy is somewhat you can push up to 5.7. I don't know. It's
synergy,
I just
actually stent design concern, the synergy stent is the Medtronic one, right?
I think
All right.
I think it can be like a 5.78 millimeter or something.
Right.
Synergy.
And
4.0,
also the
yes.
design-wise is a kind of a coil stem,
Yes.
right? And so I prefer more tube-like stems, giants or the other things.
so I prefer SJ. You can give me a suggestion.
All
Which,
right, I think it's very short stem is enough.
Yep.
However, technically very difficult to cover the ostial part, right? And very tricky one, and the diploid 4-0 first, and then we're gonna dilate a little bit bigger balloon,
maximize
so
by
5.
so 5.
I think, Dr. Park, if I may,
Can I? Hey.
Dr. Wu, if you use a 4-row stand and expand to 5.7, 5.8, there's a significant foreshortening, no? So you might not cover the ostium. You've got to be aware of that.
I probably can protrude somewhat, for example, 2 or 3 millimeters, because the length from the bifurcation to osteo is 12. So I can deploy, because I'm selected 12, might be if we can just deploy it somewhat 2 to 3 millimeters beyond that osteo. Okay. And I pick up that aerial cranial. This is my favorite view for osteo stenting.
Why not 5.0 millimeter stent? There's a larger stent available.
Okay. It's a good idea. SJ, depends on you.
We've used a renal artery stent in this situation because
Great.
it's like a renal artery. You don't want to go real high in pressure.
Right.
But probably we don't have the short stand for the
Right.
renal, because
Yeah,
renal.
I think it's a good option. The vessel diameter is big one, and so we don't care about the bell metal stand and drilled stand. The stand area is big enough to, and so
Can you check the renal stand?
maybe we don't have any bell metal
Renal
stand.
stand.
Why not the onyx? Why
The
not the
onyx is a good choice. Yeah, I guess onyx also a good
it's made
choice.
for big left main stenting,
Alright.
and then you have better support.
Let me check if they have
Alright.
the renal stenting short
Good.
and maybe 5.5 or
Good
5.
suggestion. Right? Jim, big renal artery, big stand, right?
But you don't want it too big. This is like a renal artery where if you get too
Yep.
aggressive, it can rupture and the patient
Yep,
bleed
yep.
to death very quickly.
I would use maybe 5 by 12.
But you need a stent with a good radial strength here. You're dealing with a calcified osteo disease, which is an aortic
Unfortunately,
disease.
the
Which
renal
the renal
stent.
has better.
No, we don't have.
The renal artery
Unfortunately,
stents
we
are
don't have a
stronger.
renal artery stent here.
Okay, no problem. 4-0 stand, either way, the giants were prawns.
So
And,
SJ, you propose Dians, and Tianhai proposed Onyx, and I pick up a shop maybe a Synergy. So we have to decide.
I don't like, it's just I mentioned about the stand design.
You don't like Synergy,
Yeah,
okay.
it's coil-like stand.
Okay.
So however, not so good for the ostial part, right?
I think
So probably I would take the SJ's advice. I think I can use the Dians, and we try to push by 5 after that 4 by 12. Do you?
I think a more difficult choice is a post-dilatation balloon, actually. 6.0 balloon is not available, so that larger size is 5.0. It's very difficult to oppose the stent.
Actually, we don't Okay, you don't need a 6-hole
14
balloon.
is somewhat
And
long.
we're going to make a 5. There are some plaque, between the vessel wall and the stent. The stent, effective stent area is quite enough, right?
Yeah.
So
But you can use a peripheral balloon to
don't
you know.
push too much.
Yeah.
But a short
like it.
5-millimeter
5 is
stent
15,
is going to
yeah.
last a long time, irrespective of what kind of stent it is.
Yeah.
Don't you
Maybe
think? I mean,
Zion's
it's gonna be
4
very
by
good.
12. 4 by 12. Okay. Yeah.
You need a minimal area of channel.
Okay, I find some Boston renal stent, however, that renal stent is somewhat too long, 14, 15 millimeters. So because only 12, the length of the left main, so if it's protruding too much, and I don't like it very much, so I would preserve just using, take the regular DS40 by 12 from Abbott. This is Zion's.
What's the length of the left main from the ostium to carina?
12. 12.
It's in the IVUS.
Yeah, by Ibis.
Okay.
Okay, because Maurice have some progress, maybe I don't know if you like to stay with me, and or you like to jump into Maurice to see how is the progress.
I think we'd like to see how you deploy the osteo stent.
Okay, give me that. Okay, see from
The
here.
proximal stent, must be hanging out is 1 or 2 millimeters. It doesn't matter, right? How
Yep.
you don't consider about too much about the bifurcating corona area. 그죠? Good.
Okay, should be
Aerial crane.
area crane.
But at the same time, sometimes stent can come out, so be careful, the stent is coming out.
So my secret is I would keep the guiding as close to the stent, the proximal marker. So give me a test. Okay. So, okay, take a scene.
You have the advantage that you know where the ostium is
Okay.
by virtue of the calcification.
Everybody happy this position?
Go a bit further, I think. In.
Would you show us another view, the spider view?
Okay, spider.
Yeah,
Okay.
okay.
I can show you.
Spider.
Okay.
Fantastic.
scene. Okay, from the aerial
is okay.
cranial, I seems quite full coverage, and we are not go beyond the bifurcation.
Aerial?
Okay, aerial again.
I think
Crane.
it's okay. It's a little bit,
Because you can see a very obvious calcium line along with that aortic wall. So I think maybe I need to protrude back a little bit by this view.
Yeah, protrude a little bit because the polygon is very large and you have a below position in the polygon
Okay,
part of the bifurcation.
Okay, I think I like this position. Okay, deploy it.
Yeah. Inflation.
Yeah, okay.
8, 10.
Okay, 16.
And that's why we always need a longer stent than 8 or 5 because a short stent can really move in cases like that. So a minimum 12 will be good.
So we'll be just pulled out a little bit, just fray up a little bit here. 20,
Yeah. 10, balloon.
24,
24. Yeah.
Okay, done. For avoiding that squeezing or longitudinal fortune, sometimes I would ask my assistant before deflation, I catch my guiding caster along with a balloon. Then I just can quickly engage, but not too deep because sometimes it would force for longitudinal foreshortening of this kind of osteostenting. So now hopefully I don't need another new one. If I can get past with the original 5.0, we can use that 5.0 for pre-dilatation or post-dilatation. And now more stabilized because circumflex wire was gel outside the stent. Okay. Give me the nice more low profile.
Do you feel that the gelled wire should be removed before post-dilatation?
I guess it will be fine. Usually we don't need. Or maybe let me to put the balloon in, then we can remove it before we do high pressure infiltration.
I think swallowing the guide like you did is terribly important in that situation, particularly because you're going to want to work through that if you want to do something with that middle LED. So to do it like that is perfect.
Post dilation?
Yet,
So what size? What size balloon?
5.0, same as
5.0,
before.
right.
Yeah,
think it's quite enough.
I guess if I can
5.0.
pass, because I'm afraid this is an inflating one, so I don't know if I can be, or maybe I have to use a new one. Yeah, let me try if I cannot. Okay, yeah. Let me just inflate here. Quick inflate. Okay, here.
Yeah.
Okay.
10, 12,
Okay, 20. Okay. All right.
20.
Okay, wait. Okay, deflate.
please.
I think people have to realize that's a dangerous angle. You can then pull the other stent out if it's not been fully
Okay,
deployed,
so-
because you can see it sort of hanging down at an angle like that.
Okay, so I just want to. So okay, here, like.
Yeah.
Okay, 20.
Balloon.
20. So I can see the osteo still
20.
somewhat under dilatation. Okay, done. So now I can adjust my balloons out, then we can fray up a little bit more. So David, what's your maximal pressure for this lady? Okay, 24 again.
Deflation. 24.
Okay,
Yeah.
done.
Deflation.
Quite enough.
Okay, a little bit test. A little bit test. Okay. No disaster.
Good.
Vitals good.
So we check IBUS.
Still too many wires.
All right, if you're happy, I can remove the second wrist right now. So now I can dip intubate into the osteo, indicate that the left main osteo has been fully inflated.
Is that a 6 or 7 French guide?
7 French guide. Okay, I was coming. Okay, push. Oh, no, I'm sorry. I need to go fast. Big young. Okay. All right, go from here.
Yeah.
All right. Okay. So this IBUS run.
Okay. Distal left main.
No, just still area the osteo.
Big one, right? Still 1, 2, 3, 4, 4, 5. Okay,
Circumference
circumference
joining.
12 o'clock. Base wise, almost 1, 2, 3, 4, 5, 6, 7.
Ah,
Very
under-
small.
Under dilatation.
Stand. However, I think it's okay.
What do you think we need to more dilate the distal end of the stents, or we just
Okay.
osteo is okay?
Stand position is almost perfect, right? One, at least 2 segment proximal. Stand segment is hanging out outside the ostium. However, distal part as well.
Yeah, somewhat under.
Some part of malposition. So we cannot negotiate in terms of, any big balloon. Okay, would you show us IBUS again? In that position?
again.
Okay.
IBUS again.
This is
Go ahead.
polygon part, not the left main. This polygon.
Because the distal, I just inflating, we up to a 16. So I don't know if we can use a semblance, I'm precisely not to protrude, and we can inflate somewhat higher pressure.
I think anyway, it's very difficult to oppose all stent thrusts
Yeah,
in
yeah,
this
this is
area,
an
so it's
indication.
no
Okay, go
use
ahead.
for doing the post-op.
Just,
One or 2 millimeters.
and a half segment, acute malopposed, depending on the region-wise, size discrepancy.
Yeah, this is 6
All right.
millimeters.
So,
Why don't you wire the circumflex and do a kissing, distal kissing of the stent?
The circumflex, because initially while I was getting to the
I know,
circ,
I mean,
that
just-
At this point.
I need to stabilize by 2 wires. It's usually for osteo it's easier to identify, and also it's a marker of my distal marker.
so we're going to discuss. And what do you
just
think?
take back the-
Clinical, clinically, what do you think? Does it matter?
The ostium looks okay,
Does
but
it
the
matter?
distal looks a little bit malopposed. I'll just take the same 5O balloon and go a bit distal and
Somewhat
and go
higher
pressure.
Okay.
And then we see this is a huge left main, so I'm not so worried.
Yeah, so you're not causing any trouble if we are just very precise in the distal edge.
Whatever you're going to do, you want to do it today because it's not going to be that
Okay,
easy to
yeah, okay.
decannulate
So I would do
the,
it,
left
yeah.
main.
Okay. So, all right.
Okay, Dr. What?
Yep.
Okay. We're going to just check, Dr. Boris and the
Yeah, yes,
result
it's
and the
fine,
way
it's
back
fine.
to you,
Yeah,
right?
okay. All right, okay.
Boris?
Hi. Thank you, SJ, because the patient is getting a little bit tired. So what we did at this point is go ahead and post-dilate, and we used a 3.5 millimeter short for the LED, and we went to 18 atmospheres, and another 3.5 non-compliant, but we went to 22 atmospheres.
Would you
And
show
this
us the
is
IVUS?
This is the IVUS now.
Yeah, bigger image, right? Great. Distal landing is good. Perfect.
Did you use a 3.5 balloon for left main?
Yep.
Crossover.
Why is the left main is larger?
Well, let's look at the residual minimal luminal diameter.
Minimal lumen stent diameter is almost more than 3, and the cross-sectional area is more than 7 millimeters square.
It was
I think
it
it's
measured
quite
at
enough.
9. Look at what we measured.
All right.
There you go.
Regardless
More-
of
right.
minimal stent area, actually, recent concept
Go ahead.
of proximal optimization recommends you to the larger and optimal dilatation in the proximal left main, considering the vessel size.
Good.
Isn't it right?
I was satisfied. I don't know what's so we can go with the short 4.0. There's no problem. We still have the wire. Why don't we look at the angiogram right now, and we can show you here. You see the angiogram right now. This is the final angio with the preserved circ and unchanged ramus. We could use a short balloon, but I think a 9 is pretty acceptable. What do you think, SJ?
I'd like to see it a little more round.
Okay. Well,
Okay.
Maurice, I
Yeah.
think his angiographic perfect, right? Circumflex ostium is good.
Exactly.
Ramus branch is
Just-
good.
Just to make everybody happy, I could use a 4.0 short balloon, 8 millimeter, and we'll be done.
Right.
All right?
Right. Our panel
Well,
will
thank
do
you
that,
for your
right?
help, and we can go back to the other. Thanks.
In terms of stent area-wise, is quite enough. I
Exactly.
believe so. However,
I think it's enough.
you need a plastic
Yeah, left main size was 5.
cosmetic
Nice.
dilations in terms of.
Yeah, this is more
Okay.
cosmetic surgery because minimal luminal diameter, and we look at the data, we have the threshold that we need, but we are here to please, we're aimed to please, and we will go ahead with the 4.0.
Okay, great. Did you see that? Can you?
So recent analysis of a COBIS-2 registry showed that the proximal optimization is very important when you just crossover stenting without kissing ballooning. So including left main and non-left main, proximal optimization with the larger balloon was associated with a much lower TLR rate, regardless of MSA.
Where is that data?
A COBIS-2 registry. It's not a randomized trial, but
Okay, okay, here we go.
Dr.
You agree that we are proximal here?
Okay,
Go.
great.
2, 4, 6, 8,
8,
10, 12, 14, 16,
14,
18,
16, 18,
22.
20.
Down. 22 down.
22 down.
Location of port balloon is very important. So the distal side,
Cine.
distal marker should be located to carina side.
There we go. Okay.
Okay.
And that's one last one, test.
Test please. Yeah.
Right there.
Yeah.
Okay, 2, 4, 6. But I don't want to get the circ problem. 6, 7, 8, 10, 12, 14,
14,
16,
16,
18, 20 down.
20 down.
As long as cosmetic surgery doesn't hurt the nose, that's okay. But we don't just want to do cosmetic surgery for the sake of cosmetic. Okay, ready for cine?
Yeah, ready?
Great.
Nice. All right.
Getting bigger.
So we don't want it to get too big. All right, so I think in my own judgment, I think we have a decent angiogram. We will do a final IVUS, and that's it. You agree?
We agree. Recently, the data from the New Tokyo Hospital, the crossover stenting with the LM bifurcation, the number of jade slot in the L6 ostium correlated to the narrowing of the L6 ostial area. So in my daily practice, I open up the L6 ostium in this case.
But there is data that shows to the opposite, that your restenosis in the SX gets worse, CX gets worse.
However, the L6 ostium can be opened up the short balloon. I recommend the glider balloon, 4 mm short balloon, or 6 mm non-component balloon for the L6 ostium.
I thought we dealt with that with the randomized data that from Korea, that it was better not to do that unless you have some threatening lesion to the circumflex. That just dilatation at the end and a kiss was not beneficial. Anyway, so let's continue here. I'm going to do the IVUS.
Okay.
And we will start again from, I think the distal edge, we were fine with the LAD, so we'll start from where the left main is. And go ahead. And so this is in the left main at the carina. Pull back. And this is pretty large now, widely opposed.
1, 2, 3, 4.
That's where we did the
Stand
four.
diameter is almost 4.
Yeah, that's where we did the
Right.
4.
So
And now it's the true ostium, and
more than
that's
10,
it. Okay,
12
off.
millimeters square.
Oh, above 10, yeah. All right, so 100 of nitro, and we'll be done. So if you'd like to go to the next room, that'll be great, and thank you for your help.
Okay, thank you for nice presentation. So, okay. Okay, Dr. Wu?
Yep.
here?
Yeah, we are here. Luckily, we are able to do a final high pressure precisely in the distal edge. And because we are checking the pressure wire for the mid lesion, because my assistant said he can do FFR to see.
Mid-LAD lesion, you mean?
Yeah, mid-LAD lesion. So
Alright.
we can show you the IVUS imaging
would you-
before
would
we
you-
do.
Would you show us coronary angio?
Okay, all right.
With the person?
Before.
We
Just
can
do
guess.
yeah, before.
Before.
Okay.
Mm,
All right, before.
Before.
Okay, this one.
Okay.
Okay. Yeah, this is okay, before we do this, we have a precise. So I usually using a cine, just kind of just precisely at the osteo, near the edge. So this is what I did. Very eccentric, but we are able to achieve quite a good result. Okay, following. Then after this, we do an inflation, because original only 16. Now we go to 20. Okay, next one. This is angel, and we check IVUS. Okay. So this is a bifurcation from the circumflex.
oh,
It's improving.
okay, getting better. Great.
Yeah, I'm satisfied of this result. And we didn't do further dilatation for the osteo, just one puff for the
Great.
I don't
so
think
full
that this
coverage.
malposition will increase the risk of stent thrombosis, and I will discontinue
I
DABT at the 12 months.
I don't believe too much in terms of, just like a big vessels, proximal pass, 6-8 millimeter, floor.
Yeah.
Right, no.
Can you discontinue DABT at 12 months?
Amen.
Discontinue dual antiplatelet therapy at 12 months?
That 1 year is quite enough.
Right.
In almost every case is already main stent, right? There are a number of, depending on a number of stents, we have considered a little bit, longer depth. Mid portion LAD, quiet,
I'd like to ask question to Dr. Park about FFR. I'd like to ask question to Dr. Park about FFR. You have a lot of experience. So FFR cutoff value 0.8 is appropriate for this 70 years old lady?
Just leave it around. 0.8, you mean?
Yeah, I mean FFR cutoff value 0.8 is appropriate for this 70 years old lady?
I think it's okay. Right.
Okay, we can
However,
bring it back into near the junction.
right.
The tips here and everything.
Maybe we have some new data regarding the gray zones, 0.76, 0.8, still, the D4 would be better. So, however, in some cases, 0.8, less than that, why not? We want to treat them. Sometimes just leave it alone. So in case of a gray zone.
My question is that the cutoff value will be the same for 45 years old male patients and 7 years old female patients. So exercise capacity does not matter when you regard the cutoff value?
Still, the cutoff value is constant, one numbers, right? Even that is 0.8 or 0.75. The reason why the FFR value itself is, reflected holder, those conditions too.
I think what he's saying is that he doesn't want to do this.
So go. Yeah.
I don't know, depending on
Calcified, it's you've got a
FFR.
beautiful.
However, I think it's very
Running, right?
0.8. You guess 0.8.
I guessed 0.8.
0.8, right? Jim, I guess 0.8.
It's okay. Yeah, no need. Yeah.
So, actually, resting
그래요?
PDPA is
잠깐 답답할
0.94.
수 있어요. 저희가 잘 됐고 얼마나 되는지 이제 볼게요. 약
컨트롤 했어요. 짝달리. Zeroing, please. You have already, passed the region.
Yes.
Okay, there is resting PDPA 9.3, right? The possibility of a negative FFR almost 80%, right? More than 80%.
Adenosine is running. Right now it's running.
What's wrong with this?
Borderline.
Gray zone.
Gray zone, huh?
Gray zone.
All right.
7.9. 7.8.
7 8.
It's borderline, yeah.
The meaning is the
Yeah.
IFFR, so we use in our current practice, the cutoff value is 0.9, 0.89 something, right? However, if you look at some data, matched value of a PDPA, the cutoff value is 0.92, right?
97.
It's almost 95% is matched with the IFR and PDPA concern. So I use sometimes, PDPA 0.93 is a quite, negative matched with in terms of FFR. So what I'm talking is based on our data, but it's not a, kidding.
So if this is a borderline, because 0.78, 79,
Right.
I probably would just stop
Right.
here.
Okay. Absolutely, I agree that, right? So we just D4.
All right, okay.
To be better than 3.
Okay. All right, thank you.
So last picture.
예, 파이널 지금
Right.
I'm already taking out. I'm taking out. I'm sorry. So okay, give me a little bit test. Test.
Temperature. Okay,
All right.
great.
Let's find the pictures. Okay, so
Wait,
move here.
wait,
Okay, see?
wait. Yeah. 왼쪽.
Okay. All right.
I think it's good. Perfect. Any comment on that, Dr. Jim?
I think he did a nice job. And
All right.
I think he used very good judgment not to do the mid lesion, because the mid lesion is calcified and it's not a slam dunk.
David?
I think you could go either way with this. I think certainly had it been a more active, younger person, I would have done that. I think we're then sort of swayed in part by the age of the patient and how active they are. I think that the left main has been clearly the most important thing. I think that will relieve her symptoms. If it was a high exercising individual, I don't think that would probably be the case. I think you would still probably treat that. But I think overall, taking the whole picture into consideration, the FFR, the fact that it was a severe left main, I think it was a good decision to stop. You could come back and do that again if you needed to do that. I think it would be unlikely to have to do it again.
Well, a lot of studies have shown that 0.75 is the better cutoff for increased cardiac events if you don't intervene. And between 0.75 and 0.80 is really not that important, I think. What do you think, Dr. Park?
Right. We got brand new data regarding the gray zone.
Yeah.
If you deploy the stent, it will be higher frequency of periprocedural myocardial infarction, and however, in the case of D4, it will be higher frequency of revascularization, right? And so balanced with a soft endpoint, hard endpoint. So actually, prefer the D4. The cutoff value is 0.8 is too, high. However, I really believe in our real practice, more than 0.8, negative FFR just D4. That is the main message, right? Positive FFR less than 0.8, depending on operators, right? Sometimes it's treat, sometimes it's not treat. So, however, we don't have too much data about the gray zone, so we are going to make some solid data. Anyway, Dr. Wu, great angiographic result and very nice demonstration.
Thank you.
Thank you
for the
again
assistant. Yeah.
All right.
Okay.
Thank you.
All right. So we wrap up
nice
here.
demonstration.
Okay. Thank you.
Okay, David, any comment on discussion pointers there?
I think the discussion that you've heard is a terribly important one. I think to make any decisions based upon a single number is probably a mistake. I think that you need to take into context all of the other things, what the other vessels are like, what the patient is like, what the expectations are like, if they're having symptoms. I think all of that needs to be sort of brought together as a full picture of the patient rather than treating a single number. That's what I think.
What you're saying is
in this
common
case-
sense is as important as the guidelines, right?
I'm wondering, in this case, we're quite lucky that we'll be able to dilate the lesion. What if we couldn't dilate the lesion? What would you do? I mean, the ostial left main is very calcified, and a lot of time we can't dilate. If you use a big balloon, we could have cause a dissection, a hematoma, in the aorta. I was wondering whether scoring balloon or even rotablator might be a better option to prepare the lesion first.
I think we would often use a scoring balloon for that. We would less often use a rotational atherectomy, although that would be a reasonable thing to do. But we would, for many osteal lesions, we would use a scoring balloon just to try to prevent any movement back and forth when you're trying to dilate. Because the last thing in the world that you want to do is to take a balloon and have it then move forward and get a dissection out of that, or move backwards and tear the aorta.
So if I continue to the FFR issues, so the 7 years old, the FFL measurement is the measure during the maximal vasodilation, microvascular vasodilation. But 70 years old lady cannot make a maximum vasodilation by the exercise because the exercise capacity is limited. So FFL curve value should be lowered. I have no data, then I cannot prove it now. And Dr. Park, you can prove that. Based on the age limitation, exercise capacity may be a very important variable to predict the outcome.
Okay, to be, based on our large registry data, hard endpoint optimal threshold is less than 7, 0.7, 0.69, 67 something, right? However, including the soft endpoint MACE cutoff value is 0.7879. The reason why in our real practice, 0.8 cutoff value is quite enough, including the whole MACE. You mentioned about the age concern. Just only one clinical predictors, age is depending on mismatch concerns. If we have a 0.8 cutoff value, sometimes negative FFL is more frequent, is more in older age groups. However, remaining things quite comparable, reflected older situations in just a single number of FFR. So I think it's quite typical, Right.
I think a great group of cases here, good decision-making. That was the crucial thing with all these things, is to go through the decision-making points. That's the nice thing about live cases, is to be faced with the substantial issues and then have that discussion on how you might do things, how you might not do things, and then take into consideration all the things about the patient, not just a single point in time. I think that's really an incredibly important message.
Also, that not all 70-year-old people are unable to exercise.
We hope to see you shortly then at 7 o'clock.